Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome to Airway Answers. I have Heather 𝐃𝐈𝐒𝐂𝐋𝐀 here. I'm so happy to have you on, Heather. Thank you for being here.
Oh, thank you, Nicole. I'm excited too.
Heather is a speech language pathologist and also a feeding specialist and an oral sensory motor specialist. So this is so wonderful because we're going to get to talk a lot about the Down syndrome population, which is a population of children and adults that you specialize in working with, a very specialized niche. So we're going to talk about that. But the fun thing is you and I connected years ago. We both took the first Myo Masterminds course with the Brief Institute. Oh my gosh, I don't even remember what year that was. Do you remember?
It was, I think, during the pandemic.
Was it? Yeah, it was 2020, I guess. Yes, every Tuesday we met for the course, met online for 9 months. We learned so much, and then we all met in LA for our graduation, and it was just an amazing advanced level of training and experience. So that was years ago. And I always think about you. I think about you often. I see your Instagram posts for your company, Happy Kids Therapy. And we're going to look at one of your posts in a second. I just interviewed Dr. Stefan Decker, who is an orthodontist in the UK. And he was talking about children with Down syndrome, and he's getting a lot of referrals, the youngest being an 11-month-old. And I was thinking immediately about you because it sounded like he wasn't aware that there are specialists, speech pathologists, oral sensory motor specialists that can work with these children as babies, as infants, and make amazing changes, right? Can help these children significantly. So first, I'm going to go over your bio so everybody knows who we are talking to right now. You are a superstar. Then I want to show this Instagram post you just put the other day about a child with Down syndrome that you're working with that's made significant, amazing changes. I love that so much. And then we're going to talk all about the help that people can provide for children in this realm. So let's start with Heather. So Heather, you actually grew up volunteering and working inside the doors of the Down Syndrome Connection of the Bay Area in Northern California, Danville, California. Presently, Heather works from offices in Paso Robles and Danville, California. Heather's passion for parent-empowered therapy translates directly into her oral sensory motor work for speech clarity, oral motor, and feeding development. We're going to talk about what oral sensory motor work is in a few minutes. She teaches large-scale virtual parent training classes in both speech clarity, feeding development. You're also a certified Tough Tools instructor. Heather trains therapists around the world and uses a variety and a wide range of oral sensory motor tools, hierarchical feeding programs, and compensatory strategies to create meaningful changes in breathing, chewing, swallowing, and speech. She's a leading expert in early intervention for children with Down syndrome and complex orofacial myofunctional needs. For nearly 2 decades, Heather has dedicated her career to supporting infants and young children with low tone, oral sensory challenges, feeding difficulties, and breathing-related developmental delays. Heather is widely known for her highly practical, family-centered approach to building oral motor foundations, strengthening the orofacial complex, and improving those skills for feeding, swallowing, and early communication in children with hypotonia. Heather is one of the field's go-to clinicians for understanding how structural differences, sensory needs, and myofunctional patterns intertwine in children with Down syndrome, which is the population she serves with the extraordinarily high insight, compassion, and clinical precision. Everybody go tag her or whatever we do on Instagram, thumbs up, like, link, whatever. I get all my social media confused, but go Happy Kids Therapy and check out Heather's posts. I mean, really just, they bring tears and chills to my eyes, chills to my body, watching these changes, these beautiful things that you do with these children. So I can't even finish your bio. Let me finish your bio. Heather is a highly respected collaborator among pediatric dentists, orthodontists, ENTs, lactation consultants, and other airway specialists who rely on her expertise to help families navigate complex multidisciplinary care. And Heather is also trained in prompt, sign language, orthodontic and airway education and techniques, communication, educational and reading programs, and other medical considerations. I kind of looked, you sent me your bio, and then I read
Yeah.
more about you, Heather, because there's more out there. You send me all, you shorten your bio a little too much
Yeah.
because people to really know who they are
No.
listening to right now. So I really thank you for joining us today on Airway Answers. And we're going to talk about real world strategies, therapy foundations, clinical pearls that you use to support children with Down syndrome and other issues with low tone of the oral facial complex, how to help build oral motor strength, improve sensory regulation, and establish safer and more efficient feeding skills, and optimize breathing and airway development from early infancy through early childhood, which is the work you do daily. So thank you again for being here.
Thank you for that bio. Can you please send it to me? Oh my God.
You're a
That
star.
was so nice. I was crying.
Oh my gosh. I mean, really, right? Step back, look who you are. This is amazing. And I'm going to share my screen before I start asking you everything because I want to show this Instagram thing. So let me share my screen and let's see, Instagram. Here we go. Okay. Can you see, Heather, on the screen what I'm sharing?
Oh, yes. Oh, yes.
Okay. So Happy Kids Therapy. Now I'm going to read this. This is from Heather. And you see the picture if you're watching this on YouTube, this adorable little thing, and adorable Heather, because that just looks so cute at the floor model of therapy.
I mean, oh my goodness. What a picture, right? This picture deserved to be seen. It's just beautiful. This is baby Wyatt. She's beautiful.
Okay, baby Wyatt. And I'm trained in the floor time DIR approach. And this is how we work with little ones. We are on the floor, child-led therapy. And that needs to be on the cover of a magazine or something for floor time techniques, right?
Oh, that's so great. I love that.
So some families haven't started an oral sensory motor program yet. And the worry feels heavy. Why isn't she progressing? Are we missing something? What if she never gets there? If that's you, breathe for a moment. There is so much hope. When 18-month-old Wyatt came to me, she was highly defensive to anything near her mouth, face, and she constantly chewed her tongue, soaked through outfits from drool, and only drank from a bottle. Her parents longed for two things: for her to start speaking and for her to eat table foods with the family. They were overwhelmed and unsure where to begin, like so many parents I meet. But here's what happens with small, steady, collaborative work. In under 3 months, Wyatt now accepts touch to her face without fear. Her mama confidently runs a chewing program at home. Her drooling is disappearing. And best of all, she's babbling daily and even imitating the sweetest little sounds. Tiny moments that feel like miracles, and they add up fast. If you're just starting or scared to start because it feels big, let this be your sign. Progress can feel slow. The work can feel repetitive. You may wonder if anything is changing. But one day you look up and your child is completely different than they were a few months ago. Your consistency matters. Meeting your child at their level matters. Your child's nervous system is learning, connecting, blossoming. Wyatt's journey is proof that beginnings are powerful. If you feel behind, you're not. You're right on time, and beautiful things can happen from here. DM me if you need help. This is from Heather. I have tons of resources for your family. And you also have classes that we're going to talk about. So I'm going to look at the photos. Everybody look at the photos. 3 months of progress. We started with complete oral defensiveness, bottle feeding only, so much drool, anxious, stressed parents. Look at you, Heather. I love that. Okay, look at the affect. We learned a more collaborative, family-friendly home plan, which reduced stress for Wyatt and her parents. We gave her sisters jobs too. Everyone learned to play in a therapeutic way on Wyatt's face. Sometimes it felt like there wasn't any progress, but then Wyatt would repeat a sound for the first time or let mom on her face and in her mouth without wincing, and things started to change.
Yeah.
Just shy of 3 months old, and look at closed mouth. There you go. White shirt is dry in therapy today. Drooling and tongue chewing has decreased significantly. Everyone can get on her face and in her mouth way more. She's chewing for the first time. She's allowed dad to give her a sip of his milk, and she started babbling. These are huge gains in 3 months, everybody.
3 months.
That is awesome. Let me undo my screen share so we get you back. Okay, there we go. Amazing. I mean, literally, I'm tearing. I'm tearing.
I know. This work is highly emotional. It's very emotional, and just I know that I made that post, but having you read it is like, oh my goodness. And just being able to work with parents who you feel their stress and you sit with them in it, and you don't know half of it. You don't know 90% of it, but what they do share with you, you feel. And I think that's one of the best things that I've learned through my 20 something years of being a therapist, is to just sit with people and feel what they're feeling, because that's the problem for them. And so if you can find a solution to it, then you're going to help someone greatly, right? And so I'm just so grateful for the families that choose to come and work together, or who I get to work with wherever they are. It's just so wonderful. It's such a wonderful profession.
That's so deep. So not just providing the therapy with like, we're going to get this child talking, we're going to get lips closed, but sitting with the families in that emotional aspect, listening to them, hearing their needs. That's so important.
So important. And so many of these families, they sit in deep despair, deep despair, and their children are 4. And you hear this, and I mean, it's heartbreaking that a family could have worked with, a couple professionals in their lives and already be in deep despair because they're not quite getting to who they need to be with quite yet, right? They're not using the modality of therapy that their child needs, or maybe their area doesn't have who could quite serve them. And these families are really struggling, and it's really up to parents, kind of fortunately and unfortunately, to follow through with therapeutic intervention at home, because we know that that's when you integrate it right into your home and generalize it, then that's what makes all the difference. So just knowing where the families are coming from is so helpful to being able to help them, provide some progress so that they can feel more empowered and move forward with their children. Because when parents feel empowered and children feel empowered, everybody's winning, right? And that's really the goal here, because our kids with Down syndrome, we have multiple areas that we target, right? As professionals, we know this, or we're learning about this. And so we kind of have to take all those and then figure out where to start, how to make a family feel good together and collaborative, see progress, and then they will stay with us, and keep moving forward and forward and forward. And that's, I think, the real magic right there.
Mm-hmm. And we're going to talk at one point about where families can go, but also where our colleagues and professionals can go to help these young children. I know there's orthodontists, dentists who aren't aware that these children, we can help them at a really early age before any orthodontic techniques can even be initiated. And they don't know that, or they don't know where to go or who can provide the help. So we're going to address that. But for those listeners who may not be familiar with the unique needs of children with Down syndrome, what would you say are the earliest oral sensory motor red flags that you look for in infants and children with Down syndrome?
Yeah, so it could be at any age, really, because families find you at any age. And so I like to talk about kind of stages instead of ages. I think that provides a lot of hope for families, because a child who's 2 and a child who's 9 could really be in the same phase of oral development. So we just kind of talk about phases and stages instead of ages. And I think that makes us feel a little bit better. And so low tone, low sensitivity, muscle weakness, these are really like the three big areas that we need to know as parents and as professionals when we're treating this community.
Okay, one interruption just to make sure everybody understands. So all children with Down syndrome have hypotonia, so low muscle tone of the entire body,
Yes,
right?
the
Okay,
entire
so
body.
that's
Mhm.
characteristic. So, okay, keep going.
Yes. So tone can be found on a spectrum, and you can have closer to normalized tone or extremely low tone. I tend to look at gross motor milestones and kind of see where a child is learning to walk and sitting up and doing all those things to kind of see where I think their tone might be. I also feel them. But so tone ranges and doesn't change because it's neurologically based. And then you have strength, which we know we can always get stronger. You and I, we go to the gym and we get stronger. And so we know we need adequate strength to speak and eat. We don't need to be a bodybuilder by any means. And then sensation. Our children tend to have what can be easily kind of qualified as like a Novocaine effect, like inside their mouths as well as inside their systems, their whole bodies, and it makes it harder for them to feel when they're cold or hot or when they need to go to the bathroom, or pain receptors. And so also in the mouth, it just makes it really hard to feel lips, tongue, cheeks, jaw. And so when you're asking a child, can you do this? Stick your tongue out. Can you do this? Put your tongue up. Or can you say butterfly, or whatever you're asking a child to do? Can you eat with your mouth closed? You have to realize that when a child doesn't feel what's going on in their mouth, it's really hard for them to make movement. And so just like if you were sitting on the floor and your foot fell asleep and then you were to get back up, you would never be able to walk on that foot that was asleep. You have to wait till it wakes up to actually have function of your foot. Same thing here. We have to wake up everything so that we can recruit muscles, balance them, strengthen them per the task at hand, whether that be feeding goals like chewing, drinking, or whether it be speech goals like just imitating a sound like a bilabial with your lips, or alveolar with your tongue, or just opening your mouth to say a vowel or getting air out. I mean, we start at we meet the child wherever they are, and then we progress from there. Those three areas are so important to always teach. And then I also teach that structurally our children tend to have smaller oral cavities, which makes their tongue appear larger. So their tongue actually isn't larger. It's called relative macroglossia, because the relationship of the mouth to the tongue, as well as midline deficits like tongue ties. So oral ties can be highly prevalent in our kiddos too. So we have a cocktail of issues, right, that a lot of parents and professionals aren't even aware of. And so it's so important to know about those things, especially in our kind of myo oral motor speech world, so that you can educate yourself and know how to address those things, know how to differentially diagnose those things, and then just connect with providers who maybe do, so that you can learn, or parents can, learn, or be with the right people that can support their children the best ways possible.
And this is really important information. I love the relative macroglossia. I
Mm-hmm.
always say that and use that because true macroglossia is a very rare condition.
Mm-hmm.
Relative macroglossia, the tongue is going to appear larger due to the small oral cavity, and also I'm sure the low muscle tone. And
Yeah.
these are things that you can shape in therapy and with orthodontic techniques.
Yes.
Get that tongue in, lips closed.
Yes.
Also important, you said tongue tie is common in this
Mm-hmm.
population. So structurally, the smaller mouth, relative macroglossia, tongue tie. And then also, I really found this interesting, that Novocaine
Yeah.
comparison, or that like leg feeling asleep in the
Mm-hmm.
mouth. The muscles and neurological connections need to be woken up, like you
Yes.
said. So hands-on techniques are going to be extremely important in this population. Honestly, I feel like in every population we work with, hands-on is going to be better than just verbally guiding someone what to do. If
Yes.
we can get in the mouths of all of our patients, it provides one added sensory component that is very necessary for
Mm-hmm.
achieving our treatment goals. But with the Down syndrome population,
Mm-hmm.
that's going to be extremely important because of that decreased sensory
Yeah.
feedback.
Mm-hmm.
that's good to know. So can we talk about that? How do you guide parents? How do you get in these children's mouths? We have a lot of the early intervention age group that it takes, it's a whole process to just be able to get in their mouth, to
Some,
allow.
yes, sometimes yes, and sometimes no.
Okay.
So of course there are many different types of children, and not everybody's the same by any means. We have orally defensive children. Usually that's from medical trauma, or maybe they've had trauma with food. We have kind of what I call is maybe like a typical child with Down syndrome who was really sensory seeking because they're not feeling very much. And so when you get in their mouth, they're like, yes, and they come forward. And that's kind of a traditional, that's how I think of kind of most of the kiddos.
Okay. So,
But
so
then
the
you have,
majority, you would say,
yeah.
do you welcome that?
Yes, yes,
Okay.
because when they can start feeling their face and their mouth, and they can start moving more, right? And
Yeah.
it's like, oh, they require more input. So more is better.
So if
In that.
Dr. Decker is watching, when I talked with him in the interview,
Mhm,
he talked about an 11-month-old that
mhm.
he saw, and it sounded like he was kind of the youngest child he saw with Down syndrome, and what does he do? And he started massaging the palate, and he was guiding the parent, this is something you can do. And the
Yeah,
child wanted that feedback and put his hand back in their mouth. The child
yeah,
really wanted that. So that
yes.
goes exactly along with what you're saying.
It's right. It's so true. And so traditionally, with that low tone and low sensation, you would require more input. And so, yes. And, you are always like responsive to this child, right? When the child is moving towards you and opening their mouth, they're letting you in. And you would never like force yourself on a child. And then there are children who go through phases of willfulness, right? And so every parent knows what that looks like. It's like, no, I do it kind of phase. And so, yes, there are many different ways in which I guide parents and professionals to work with children. It's just a starting point. And most of the time, it's just, I call it making friends with the strategies or making friends with the tools that you're about to introduce. And so that whole first phase, whether it be a month, a couple weeks, or whatever, it's just about getting everything out that you want to introduce to your child, whether it could be your hands, even on their face, and creating a family environment that is very conducive, low pressure, and fun to whatever you're going to introduce. So it could be tools, and it could be massage, it could be intraoral stimulation, but including the rest of the family really creates a lot of fun, and it doesn't feel like therapy because our children tend to need a lot of different supports. Making something fun and making it part of a routine the family already has is kind of like a work smarter, not harder technique, right? And then including all the rest of the family just makes it feel like this is what we do. It's not like this is what is done to you. And I think that's really important. So when you look at some of the Instagram posts from the families that post after they've taken or while they're taking my classes or working with me, you'll see that everyone in the family is always doing whatever I have guided them to do. And it works, and it's beautiful, and it's kind of changing the dynamic in the way I think about therapy, which is really nice. And if you can kind of see like behind me, oh, like this is my office. It's
Let's
not sterile. It's not, it's very much like a home.
Can you
And
show your poster that you have up?
oh yeah,
I
absolutely.
told Heather I want to live in her office. Like, can I sleep there? It looks so cozy. I don't know if you could. She has this great like Happy Kids Therapy poster with all these
Oh,
beautiful kids that she works with.
oh yeah, this is one of my
Such a
favorites
great
here.
space. Look at this. Oh my gosh. And I followed your post, so I recognize one of the kids up there.
Oh yeah, you should recognize many of
One of your moms.
them. Oh yeah.
Speak so highly of you and post all about you. So this is great. What's the youngest age that you've worked with a child, or what would you tell parents and other therapists? What's the youngest age we can begin helping these children?
So there are wonderful people out there that do lactation support, like Jill Rabin. She's an SLP that specializes in breastfeeding support and adapted baby-led weaning. She's wonderful. So lactation would be great at first to just help support the oral sensory system and get those muscles moving and compensations, and make sure we don't have ties, and work with what we have. And then building the oral motor skills is just what we want to continuously happen. Our kids tend to kind of stall out or use compensatory kind of funny things, and that's just what happens. And so instead of rehabilitating down the line, how great would it be is, if we didn't have to do that. So getting a child really early on and having this professional network of people, we're like, oh, this person is so wonderful for this. And then we move into chewing and straw drinking and spoon feeding, and we make sure those come in. And because those are coming in correctly, then we have more oral muscle balance happening in the mouth, right? And then of course speech is going to emulate that. And so I tend to work with children that are 4 months and up. I don't work in lactation. That would be a wonderful goal one day. But I tend to work with a lot of children through those early phases of feeding and oral motor, just kind of getting parents very educated on those things we talked about, and then helping them move through the feeding, knowing that that is going to impact the speech, because every parent's main goal is speech clarity, is for their children to be known, seen, heard, right? So that they don't have to be their interpreter for all of life. And that's what every parent's goal is for their child, right? No matter what.
This is perfect because this leads into what are the foundations for speech clarity, because that doesn't happen right away. So
No.
what we're talking about, lactation,
Yes.
that breastfeeding aspect, and it'd be
Mhm.
great to talk about some of the breastfeeding challenges these children may have, but also other early feeding and muscles and oral motor that all leads to
Mhm.
attaining speech. So can you talk about some of
Yeah.
those foundations and also breastfeeding and
Yeah.
everything? Oh my God,
Well,
I couldn't put like
okay.
20 questions at once.
Breastfeeding is probably like a whole another podcast with the right person. But what I can speak to is many of the parents that I end up seeing a little bit later tell me that they were not able to breastfeed. And then their children end up having some other feeding issues, like children are stuck. They're not moving through textures. And that is because the oral motor system is just stuck. It is not developed properly. And so children are smart and they're like, nope, I'm not eating that because I can't. I physically don't have the movement patterns necessary to do that. So I'm not letting you put table food in my mouth. I will stay on my bottle, or I will stay on purees because I can manage that and that's safe. And that's where we see this defensiveness and these feeding challenges. So many of the children I see for feeding have pretty restricted tongues, I would say.
Mhm.
It's not all of them, but this is clinical, right? This is what I just see down the road. A lot of the families that end up taking my feeding class, we look at the structure and we start thinking, what's happening here? We've got all the symptoms, right? It's like the high palate and the low tongue and the tongue that doesn't quite move very much. It's perhaps restricted. And then we see all these like associated issues that come along with that, like breathing issues. And it just like all of the traditional Mayo kind of stuff.
With the feeding, and those can be foundations for
Yeah.
speech, and that low tone, low sensitivity,
Yeah.
and tongue tie can cause that child to get stuck at certain
Yeah.
feeding
That's true.
stages.
Yes.
And
That's
that's
right.
safety reasons. That makes sense. The body is like rejecting new
Mhm.
sensations because there's fear. It's not ready
Yes.
for that. And then so it sounds like you have to build these areas before.
You do. That's exactly right. You have to build the areas. And what I tend to see is a lot of like tongue overcompensation, right? The tongue works as everything, the lips and the jaw and the cheeks. And it is the only one working. Highly unfair. And so what happens like with this baby Wyatt, she's only on a bottle. And so what has to happen is a lot of times we don't use food. And that's kind of one of those misconceptions. A lot of times parents will go into a feeding therapist and they will try to push food on a child who's very defensive. And so what's missed is that there are oral motor deficits. And so what we do is just build up the motor plan for chewing, right? Or for drinking in a different way. And we help children with different devices and tools just to help build up the system. It's called a pre-feeding program. And Lori Overland and Robin Markle Walsh have a sensory motor approach to feeding. It's a book. And they really teach about pre-feeding programs and preparing the mouth for a skill before you do it, right? It's like, I'm going to teach you how to do this so that you feel safe and you feel good about it then, and you are confident. And then you're going to say, sure, I'll try this, and sure, I'll try this food. And so we have to teach skills before, right? We get in the pool, or we give the food, that's so important.
What about tongue time?
Mm-hmm.
So if that is more common in this population, how is it addressed differently than a child who didn't have such a diagnosis?
I know this is a rough area for me personally, because I feel like I'm on an island. And if you're watching this and you are a professional and you support this population and you have experience in this area, I would love to connect with you. I know as professionals, we get so into what we're doing that we forget to connect. So this is so important for me. Please reach out to me. I would love to know you and your perspective and hear about it. What I've found clinically is, because of low muscle tone and because we're worried about the tongue impeding the airway, and our children with Down syndrome have this higher risk of sleep apnea because of low tone and also facial growth, we have to be really cautious. So we need professionals that are really educated to make these nuanced decisions as a team. What happens is we're overly cautious because we're not educated, and then we just don't do anything. That's the heartbreaking part, when parents maybe even have more education than professionals at this point. And then they're like, but I need this, and I think we want this. And then professionals are like, oof, I don't know. And I know we do no harm, and I get it, but we do need more people that are specifically treating these areas so that we can collaborate a little bit better. What I've found is that children who have tone that are closer to typical, when we do releases, people will release them, right? Like, more, because they're not at risk for their tongue falling back. Or we could do partial releases. And so, of course, we do all the therapeutic intervention first, and that kind of like pre-work can take us a year, can take us a long time. It's not like 6 weeks and then we go in, right? It's like when we have an evaluation, I make note of it and I talk to the parents about it. And then I say, we will continue this conversation as your child progresses, and we will see the implications of this as we progress. And we can have this conversation more and more later.
That sounds like a wonderful way to approach it, because it does make sense when we have generalized low tone, smaller mouth. We need to be more cautious and aware of these things and that risk of sleep apnea. So do you find these children are getting orthodontic expansion or techniques at a younger age? Because that would probably be one really important piece of the puzzle to get more tongue space, get that jaw growth. So what are you seeing in terms of orthodontic realm, or what would be ideal orthodontic?
I know. So I'm so lucky because I was in the Bay Area for so long. And so I've worked with Dr. Brian Hockel, and he has a daughter with Down syndrome and a sister with Down syndrome. And we have co-treated so many children with Down syndrome, which has just been like the dream, right? And so expansion, I feel like parents, because they're becoming more educated, they're pushing it younger and younger. And so it pushes us to try different things. And that's really neat. I've seen growth in him and his practices and me and mine. And it's really cool when parents get involved. It really pushes the needle, which is great.
That's the
That's
best
what
way.
we do, right? That's what we do.
Yeah.
So expansion, of course, we need space in our mouth to house our tongue, to be able to breathe. And then because of the risk of sleep apnea is higher in our kids, the facial growth coming forward is even, more important, right? It's like so important for everyone, but arguably
That's what I was
even
gonna say
more.
too. It's not just transverse expansion, but forward growth of the
It's
jaw.
yeah. And they use like a forward growth face mask. And I'm sure there are other ways in which, and this is obviously not my realm, but it also is so difficult to move through all of these things. Like the things that you think about, you work with a traditional case, maybe a typically developing person who can follow directions and logically do things and not have sensory differences and kind of move through myo and move through expansion and move through releases and all that stuff. It's just like so much faster. And perhaps that's like the only thing they need to work on. But with our families, they have all the things that they're doing, PT, OT, speech, feeding, they might be like at a doctor's appointments all the time. I have cardiac issues, gastrointestinal. There's like 10 things, that they're always doing. And so truthfully, expansion or tongue tie release, or I don't know, it just might not take precedence. Or you might get to a point where that child was medically fragile for so long that the parent is just climbing out of the hole, right? Of exhaustion.
Yeah. Bless these parents. It's a lot of things to do and to think about. And I
Parents
think,
are amazing. Parents
yeah,
are amazing for
yeah,
what they do for their children. And I work with incredible parents who work so hard as a second and third job to not only take their kids to therapy, but to do it all at home as well. And then digest information and advocate, right?
right. And I think this is a good lesson or good information for dentists and orthodontists that if you do have a parent who has a child with Down syndrome come into your office ready for that step,
Yes.
this is an important piece. If they're not ready, you might not see them in your office. You might not see them in an orthodontic practice, but if they've heard expansion's good, they're ready to take on that
Mhm.
step. This is going to be an important component to allowing more tongue space. Do you
Yes.
find these children, they're going to benefit from your work, your oral sensory motor hands-on techniques to
Mhm.
accept orthodontic appliances better when you've already been working with them?
Yes, absolutely yes. But then there's probably, for many children, the next step is probably going in and having regular 5-minute visits and having some pre-planning. And that, like, what are we going to do in the next visit? Oh, we're going to use whatever, this tongue depressor, and I'm going to count your teeth, and we practice it at home and then we practice it there. And so some children need, if dentists and orthodontists can be agreeable and amenable to, parent brings the child in once every couple of days to do something like that, or once a week to just do a 5-minute count of the teeth or something like that. I think we can push kids a lot farther and have their needs met. But there almost needs to be another entity that does like special needs training for all ortho and dentists on sensory and just kind of like moving the needle just a little bit, right? Because they don't have time to know how to do that, but that would be like a great service.
Oh, that would be amazing. We're just
Mhm.
trying to get orthodontists to start seeing kids at a younger age because there is probably this lack of training, right? Even just working with typical children who have,
Yes.
typical behavioral issues, but that would be amazing. And I would think there are specialists. I know we have
Mhm.
in our areas dentists who are specialists in working with children with special needs. I don't know about orthodontists, but that would be really important in any training
Mhm.
program because it's going to help that doctor work better with all patients. when you can
It
understand.
is with
Right?
anybody that's young, right?
Yeah.
And now that this kind of like airway dentistry and expansion at younger age is becoming like more known, I think, working with any type of toddler, right, and children with special needs who might present similarly or have some sensory differences that really need to be addressed to come into this office. I think that would be a great idea, actually.
Yeah. That
Mm-hmm.
that sounds wonderful. And I'm
Mm-hmm.
wondering, does this population of children who have Down syndrome need a specialist or a person who specializes in oral sensory motor work or myofunctional therapy work or feeding therapy? What type of specialist would best to work with these children? And how have your techniques and training in these different approaches benefited you working with these children?
Yeah. So 100% an oral sensory motor background is so imperative if you're going to work on oral motor development, feeding development, and speech clarity development.
I feel like there's a lot of social media groups, and I'm trying to provide my input and help people understand. I think it's very confusing for parents. Like, what is myofunctional therapy?
Yeah,
What is a speech pathologist? What is feeding therapy? What is oral sensory motor?
I know.
So I did an interview with Robin Merkel Walsh, kind of
Okay,
differentiating what all those are. But
great.
can you talk specifically, what is oral sensory motor work and how does that just differ from myofunctional therapy?
I always like to take things apart like pretty easily. So oral is of the mouth, right? Sensory is what we feel, and motor is just that motor system firing and are we able to move or not? And so because our kids have that low tone, low strength, and low sensation, we really have to help regulate their systems so that they can feel, so that they are strong enough, so that their muscles are balanced. And so in my mind, a person who is an oral sensory motor therapist does that for people, usually with differences in tone and strength. And that those needs for our children with Down syndrome are more complex. And
What
so
training would that person like, who is an oral sensory motor?
I think usually a speech pathologist is an oral sensory motor trained, right? You are a speech pathologist and you are trained in oral sensory motor techniques, which just means you use techniques to help children turn on and activate muscles to balance them and strengthen them for the purposes of proper feeding and speech clarity development. So a myofunctional therapist traditionally, you can speak to this, treats children what ages?
We usually say age 4 and
Yeah.
above
Okay.
because of those foundational skills that
Yes.
are required before that age.
Yeah.
So we talk about age 4 and above because a myofunctional therapy, quote unquote, program requires the child to be cognitively aware of what are the goals,
Yeah.
it be able to imitate, have those foundational
Right.
skills. So for special needs population, we would,
Starting.
yeah,
Yes,
exactly.
we're
So
just starting a little bit lower. And so we are helping build those skills in more passive ways and helping children connect to their bodies in more passive ways, usually through like feeding techniques and using other tools. And so a great company that teaches these programs in a hierarchical way is Talk Tools. And so they are a continuing education company. It really started on the basis of oral sensory motor or oral placement therapy. And Sarah Rosenfeld Johnson, she started that company, and it has grown to not only do oral sensory motor, oral placement therapy, myofunctional therapy, and they do speech, breathing. They do so many. They have so much content now that they teach professionals in this area. But we really talk about how children with special needs really need a speech pathologist in this area. And then, a myofunctional therapist like yourself, like what you just said, requires a child to do so much, requires a child to have so much control over their mouth and to follow directions. So it's a do what I do kind of program plan. Watch me do what I do. What I do is not like that at all. I help facilitate movement in a child's mouth to get them to that point. And then really a huge goal for me is to get them to a point where you could work with them.
I
And
love
that would be like I mean, that is like the dream, right? And like you have graduated, you can now do higher level work with any myofunctional therapist. That is the dream.
Okay.
And so, but our kids, independent of age, they can be 7, 8, 9, 10, 12, 15. They can still really need the oral sensory motor component where I'm helping you connect to your body, build your skills in a more passive and active way, depending on your age and stage.
So with the special needs population, we don't say 4 years and above is ready for myofunctional
No.
therapy. This could be 5, 6, 7, 8, 9, 10. It
Oh, yeah.
depends on their stage,
If
not
you've never gotten any oral, I call it oral sensory motor work in your mouth, you would start with an oral sensory motor therapist. You would not start with a myofunctional therapist, in my opinion. In my opinion. Now, if that is the only person you had in all of your, area, and that person could break it down for you and use some oral sensory motor techniques to help you move you through that program, then in essence, that person is an oral sensory motor therapist. They have figured it out. But I just think of myo as being pretty high level, and where I start is here, and the goal really is to get there.
I think it's important also for other professionals and parents to know that not all speech pathologists have specific training in oral sensory motor and feeding therapy and working with the early intervention population in those realms. So when they're looking for a specialist, they also want to check on that aspect. Do you work
Yeah.
with the birth through the 3-year-old population? Do you have training in oral sensory motor and feeding therapy? Because there are many speech pathologists who don't and may work with children more on language delay and speech and things like that and aren't as trained in
Yes.
the oral sensory motor aspect, which requires specific advanced training, right?
It does. I mean, I trained for years in this area with Sarah Rosenfeld Johnson, the founder of Talk Tools, and I was mentored by her for years. And I am so grateful for the families that, allowed me to work with their children at that time. But it really took a lot of mentorship for me to kind of get it. And so, yes, it does. And I will never forget this one little girl that I completely treated incorrectly when I was new, right? When I was an EI therapist, my first 5 years of work. And I had this beautiful little girl named Liz, and I'd go into her early intervention program, and she'd lay on the floor in this like starfish, those little kid outfits that are just like a onesie, it's like snow. And she'd lay there like this on the floor, and I'd say, moo, bah, like oink, oink. And guess what? She never spoke. So weird, because I never touched her. She didn't have stability in her body. I could have like sat her up. I could have got on her face, in her mouth, helped her connect to her body so that she could start imitating. But I never did that. I never woke her up. I never worked on her muscles. It's just like the body for our kids with Down syndrome. It's like they get PT, they get OT. They just need, I call myself a physical therapist for the mouth. It's just getting in there, getting things active, balanced, reducing compensations and stronger, and then working towards the goals, feeding, chewing, all the things, and then speech sound development, putting sounds together, all of it. They're just
manual therapy.
plans.
It's like what PT would say, manual therapy, guided hand-based therapy. So what are some of the tools you use? And also, I mean, it makes it very clear, your example, that not all speech pathologists might be trained in this technique. So that makes that clear. What about people who aren't speech pathologists, but those who maybe are trained in orofacial myofunctional therapy? How is this also different than like, okay, I'm going to put my hands in the mouth, I'm going to use a button pull? The techniques you're using as an oral sensory motor specialist are tapping into a hierarchy that you're trained in. You're looking at reflexes. How is that a different level than just some of the hands-on tools that some myofunctional therapists might use? Does that question make sense? I want to separate how oral sensory motor is separate from myofunctional therapy and also separate from just regular speech therapy. How is that,
I think that each provider kind of has their areas in which they were trained. And so as a parent with a child with Down syndrome, what I do is provide so much education on who to go see that's going to align with your child's needs. So many parents come to me and say, why have I seen 12 speech pathologists in my child's life, but none of them have ever talked about oral sensory motor therapy, and they've never started at this level with us. And now that we're starting at his level, we're seeing progress. But why did it take 12 years? And I think it's just the education is not quite out there. I paid a lot of money for my education. I didn't get it in graduate school, and I had the population to serve to support the need for the education, right? If you're working in the schools and you only see like 2 kids a year with differences in tone, maybe you're just going to do AAC because there's a need there. But, or maybe you're going to do language. And, if you're working in a clinic and you see a variety of kids, that's how I was my first 5 years. It's like, who's walking in the door? I don't know. I'm not going to go full, I'm not going to spend all of my money and time on this one type of therapy. And so, but it's a huge disservice, unfortunately, to our children who really need it and who need somebody that understands it completely and then can help integrate it into a family model. So you're right. Not all professionals are the same, and we use everyone for their gifts. And so maybe a traditional feeding therapist just works on textures and maybe chains foods, but that's not working on muscles, right? So that maybe isn't the right person for our kids who have muscle-based issues. And then a general speech therapist might say, look at me, say this. That's what I was doing with Liz. And then that's not working for our kids. Or a myofunctional therapist who might be too high level, and maybe they are, if they're a speech pathologist, they might have a lot of training in early intervention, and they might be able to morph that into working on sensation and stuff. We learn about all these things in school, right? But if you don't have that learning and that knowledge about swallowing, feeding, if you don't get all that, and behavior modification and sensory and all that, if you don't get all of that in your training and you're just trained in a couple of myo classes, then you're missing some major components, right?
That was a perfect answer. That is so clear to me. That was a really great way to decipher it all out, because I'm not a feeding specialist.
Yeah.
And I refer those little ones out to someone else in my area that is also a speech pathologist, but is trained in that technique.
100%.
So
refer.
yeah,
Like,
it's
I'm
not like putting me down. I know my skills are, I know what I'm good at.
I know.
And gosh, I would love to be trained in everything. I just don't have the time, the
You
money.
just don't have the time. There's just not enough time.
I know.
This is why it's so important to build communities, which is what you're doing here, which is wonderful.
So what are some of the tools or techniques you use with the early intervention?
Yeah, absolutely. So I use a lot of resistive work for chewing. So just simple chewy tubes. I do a lot of just learning to chew, learning to move the jaw, because when you're giving the correct movement pattern for chewing, you're getting tongue tip lateralization. And then after lateralization comes in, elevation comes, and that's where we start seeing more speech sounds and we start seeing better swallowing patterns, right? So just some basic bilateral or unilateral chewing on resistive foods or resistive tools is really wonderful. I use the Talk Tools bite blocks, which are for jaw grading, and they help our kids grade their jaws appropriately per the speech sound that we are trying to get them to say, as well as per the conversational length sentence, we're trying to get them to grade for. We know jaw stability is really kind of we need to make sure everything's turned on. Second, jaw stability is, I think, number 2, I guess. I don't know. Number 1, really, in my mind, I'm always like, if I had a shirt, it would say like the jaw or something, because it is so important to unlock everything else. And the way that Sarah Rosenfeld Johnson teaches it is that dissociation in the mouth starts with the jaw, and it is the foundation. And so if it is weak, then the lips, tongue, and cheeks, they can't separate and do the jobs that they need to do. And so I teach so much to parents of how to identify jaw instability so that they can start working on it. And parents can do this easily, and professionals too. It is not rocket science to sit at home and chew up and down in an aligned pattern, and it will make a lot of changes in your child's overall clarity, even independent of not working on a bunch of other things. I have many parents that are finding they have great testimonies in like 9-month span. We just did jaw work. We might have done we just a little bit oral sensory, like turn it on kind of stuff, and some jaw work. And you see their speech at, with a 9-month difference, and it's like life changing. And parents can do this all themselves, or therapists can help. I love these tools too. These are talk tools. They're called Apraxia tubes, and Renee Roy Hill made them. There's another one too, but this one's for ooh, it's for placement for sounds, and oh, for placement of sounds. And she also created these. These are my favorites as well. This is the M sound and B and P. So I use these all day, every day when I'm helping people with Down syndrome get through that first stage of like bilabials and some early emerging vowels. So independent of their age, I use those tools a lot, and they are placement tools. It just helps the mouth feel where it should be to create that speech sound. So improved jaw will unlock everything. And then we start working on some lips and tongue movement. I also like the talk tool straw hierarchy a lot. We really work to retract the tongue and get out of a suckling pattern into a sucking pattern. And they have all these tools that are built in hierarchies that look like toys, but when they're used correctly, then we can really make a lot of oral motor changes with them. And I think different companies make things like this as well, but this is for tongue tip elevation and lateralization. So what Talk Tools has really amazingly done is just created some supports for people who just needed them. And once the supports are no longer needed, you don't use them anymore. They just help the mouth move in the way that you want it to. And then once the child can do it, you take it away, and then you move them up and up, and you just continue that development. And they're just supports. It's like a knee brace. It's like, you use it until you don't need it anymore, and then it's gone. And so they're just wonderful.
I feel like those tools are important and can be used with any child with speech delay. When we get hands-on, give that additional feedback, that's going to help even a child who says the R sound incorrectly, right? Don't keep saying imitate me. Get your hands in there. Use prompt techniques. Use hands-on tools for any child. So I just think those are beautiful. Plus, they look beautiful. I love all the colors of those tools. Great design style talk tools. I want to ask, what about kids with strong gag reflexes? How do you work to overcome that?
That's kind of like a child like Wyatt, perhaps. It's like a defensive child that's maybe had either like a tongue tie that's hasn't pushed back their gag, or that has medical trauma. So you just work in a very systematic approach. And I usually use the whole family. And for Wyatt, it was getting her sisters involved and, getting all over her face, getting in her mouth at all times. And then everyone's doing it in the family. We're kind of decreasing the anxiety around. We don't move straight to food. We move up a child's body and we watch them, and we make sure that they're feeling good about it. And the second they're not, we're stopping. And we are really reading body language. And this is a conversation between me or the parent and the child, right? We're not ever doing anything to you, but you're just systematically moving more towards the mouth as you build trust and you model. And I mean, these programs were taught to me by, I think, maybe Lori Overland, and maybe I use some of hers and have morphed it into some of mine. But it's just about really recognizing when a child feels a certain way and making sure you are respecting, how they feel, but pushing just a
Yep.
little bit,
What
right?
is
I have
that
a
zone of proximal development? So I
Mhm.
remember that in my psychology training, we wanted to step a little bit outside of what they're capable of doing, but not too far outside. You kind of pull them
Right.
out, right? So, okay, we
Based
have
on
like 1 minute
yep.
left, right?
Yes.
And I have a million more
I
questions.
know.
Maybe we do a part two because this is so fun and insightful. But I did have a little bit of questions from Dr. Decker and Dr.
Yeah.
Hockle, so
Okay.
airway orthodontist,
Yes.
airway dentist here. So Dr. Decker was saying, what can we do to help that doesn't cost a lot? Are you able to answer that in like 30 seconds?
Well, all I can say is as part of kind of my personal business outreach, I'm trying to reach as many children as possible given various price points, right? So I do a lot of consulting. I have a lot of courses that parents can join to build home programs with my guidance from the comfort of their own home. The regular therapy model is, one-on-one, but what I'm trying to do now is through these courses help empower parents to do things for less amount of money if they do not have providers locally to support them. So I have many different kind of touch points and price points in which families can find high level service. They just have to come to me. And then if you're a professional and you also do this, then you let me know and I can help families connect to you as well.
So Heather is a
Mm.
great resource. You are a great resource, Happy Kids Therapy, that you can help parents or help guide professionals. Where can they go? What's the next step? So we
Yeah.
will definitely have a link to your information.
Okay. Yeah.
Depending on where the parent lives, what the child's needs are, what stage are they in, you can
Hmm.
help direct what a good next step would be. Um,
Absolutely.
this is great. And Dr. Huckle was also asking if, well, it was kind of a similar question, like if this is a niche,
It
this
is.
training expertise you have, and it's so critical that what are resources for how they can work with their child if they don't have a provider nearby.
Yeah.
So it sounds like even reaching out to you to help provide
Yeah,
some.
I mean, that is why I started these large scale speech and feeding courses. I mean, I serve hundreds of families in these courses per year, and I work with each one of them individually. I consult with each one to help individualize the course to their child's and their family's needs. So that is the way you can. If you do not have a provider locally, come take one of my courses. My
Yeah.
next speech course runs in March
Okay.
and I do them twice a year, but they have hundreds of families in them. And
So these are
so
parents. This is a parent
these,
course.
this is a parent course.
Okay.
Professionals are welcome to take them, but they don't have CEUs attached to them yet, I guess. But I really might, I am, but
Yeah.
you would absolutely learn,
Okay.
great.
And on your website, is that where we find the
Oh yeah,
information?
happykidstherapy.com,
Okay.
speech class, feeding class. I have one-on-ones and also I do intensives here in my office. So I have many families that come in for the week and we really work hard to train parents, empower parents and identify children's needs so that they can go home and do this with their child.
And can other professionals learn from you and do an intensive
Yeah.
in this?
Yeah,
Okay.
absolutely. I do mentorship all the time
What a
online.
great use of your expertise, because sometimes, we might get stuck just doing our daily therapy with the patients, but to be able to have an expert like you that can reach out to help so many families and so many professionals because you're mentoring and offering this help is just so invaluable. And I think it's amazing to have you as accessibility, because I find a lot when I go and lecture, just the early intervention population, dentists and orthodontists ask, well, what can I do? I have no
Mhm.
idea. I didn't know
I know.
that there's help for these children. And
Yeah.
who do I send them to?
Yes.
To
There's a
know,
need.
here, talk to
Hmm.
Heather. She can help
Yeah.
guide, here's some
It's
talk.
true. It's true. And
Yeah.
whatever their needs are, we can find the answer to them. You know what I mean? That's what we just do is we just can continue to innovate and fill the need so that people feel supported.
And build those connections, because help
Yeah.
is out there, even though it might be difficult to find. Look who I'm talking to. I've got Heather here.
Mhm.
There is help. There are people that
There's lots.
specialize in working with
Yeah.
families. difficult populations who have many needs or many challenges. And I don't mean difficult to work with, but I mean multiple complex issues is so wonderful. So I want to thank you so much for just sharing all of this knowledge and information. I mean, my heart goes out to you. You are just a superstar. Thank you
Thank you for having me. Thank you for having me and for making this an important topic.
You know what? And it deserves a thank you for all of the training and advanced coursework that you took to get yourself to this level to be able to help so many people. So it's really just wonderful. Thank you, Heather.
Thank you, Nicole.
Take care. We'll
talk. Bye, everybody.
Bye. Thanks. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your Airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.